احنا بس عايزين نرحب بدكتور إلهام أستاذتنا وبتشرفنا في كل مكان. Now we will have our last session with Professor Natalie about volume targeted ventilation.
Some of this information about volume targeted ventilation we've talked about throughout the day yesterday, so I'll be a little bit brief and try not to restate for the third time some of the things we've already talked about, because there's a little bit of overlap with these. So we'll look at some of the different modes for volume targeted ventilation. As we've said many a times, each ventilator manufacturer gives their own name and has a different type of algorithms of which they use, and they're all copyrighted, so nobody else can use them. So we'll do a little brief difference of all the different types of volume modes that you can use. What the data is out there to support their use, and what are the challenges which actually using these volume modes. So there's volume limited, volume guarantee, volume control, volume support, and then we have our hybrid modes too. Some of these are a hybrid, that it's really a pressure mode being delivered with a volume target, and pressure regulated volume control. Pretty much all of these are those adaptive modes, and how they determine the volume, whether it's one breath as a sample breath, multiple breaths if it looks back. It all depends on the manufacturer, so whichever ventilator you're using, you really want to look a little bit more in depth into how the algorithms are, because they're going to be different from manufacturer to manufacturer. There's nothing out there proven or comparing modes of volume targeting against each other to see which algorithm and which ventilator is the best. That really hasn't been done. So looking at some of the data, there was a Cochrane meta-analysis that was done in 2011, which gives us some really great information to go over. And it looked at comparing volume-targeted ventilation to a pressure-limited ventilation and in infants. And their primary outcome was looking at reduced rates of death in BPD, which again, nothing long-term. But then they looked at air leak, cranial ultrasound findings, and looking for neural development pieces as their secondary outcomes. Again, these are all retrospectively trying to combine some together. So when we looked at in-hospital death, for some of these, there was you can see there's a little bit of a small overall reduction in death with the volume targeted group versus the pressure, but it's very slight, and it's still kind of crossing over that line. And part of the problem and challenges that we have within this meta-analysis is all of the studies that they're putting together use different modes of volume targeting. Therefore, the algorithms were different. It wasn't one baseline type of ventilator with one algorithm for use, nor was there, some of the studies had really good protocols so that they used the same type of ventilation strategy within the same ventilator, and others didn't. They just used one mode or the other according to whatever the attending physician wanted to do that day. So that's a challenge. Also, in looking at, and these are two different patient populations. So this is an overall for in-hospital death, and then we're looking at in-hospital death for infants less than 1,000 grams. For the younger infants, there's a better, slightly better, because we're touching the line, we're not going over it, reduction in inpatient mortality, but it's very slight, and you can see there's a couple studies with fairly larger numbers that really are pulling the forest plots there. When looking at death or BPD at 28 days as a definition for BPD, there is kind of a slight improvement. Again, this is an overall group when comparing the two ventilation modes. But when we take a look at death or BPD at 36 weeks, looking at a different ventilation, our overall number is not even, we're not touching the line anymore. So it's still slight, it's still not hitting one, but it's still a bit of a benefit. Then looking at death or BPD at 36 weeks for infants that are less than 1,000 kilos or 1,000 grams, it's a little bit slighter. And these are very slight differences. There really isn't an overall overwhelming, wow, there's a really big improvement there when comparing all of these studies together. The need for muscle relaxants was a little bit bigger, but there's really only a couple studies that are really contributing to this overall. But you need less muscle relaxants overall, which is a huge benefit, and all the benefits that come with not having to use them really weren't completely studied here. Duration of mechanical ventilation overall. There was a slight increase in improvement with use of volume ventilation, that we spent less days on the ventilator. And then also how much oxygen was needed. There was really no difference in the two different types of ventilation. PIE, there was actually the flip in the opposite side. We were actually favoring pressure a little bit, still on the line, but slightly over to the right, where it actually sees a benefit for pressure when seeing PIE, and increasingly so within our infants that are less than 1,000 grams. Looking at grade 3 or 4, IVH or PVL, overall, there's a benefit for volume ventilation. As we've said, over time, it has that more stabilizing effect for ventilation and oxygenation, less asynchrony, and we think that the swings is what's really causing that problem. And similarly, with our infants, when looking just at that population who are born at less than 1,000 grams. When looking at severe disability, and this was kind of an overall bucketed term that they looked at, and there really wasn't that great of a difference, but a slight increase that's favoring the volume targeted ventilation over pressure. This review was kind of updated not too long ago, published in 2014, looking at any studies that were done since that last review occurred, and this was published in not as a Cochrane, but at Archives of Diseases of Child and Fetal Neonatal Diseases, and they showed that the risk of BPD was actually better with volume targeted ventilation in some of the newer studies, and they were all updated studies, which was, it's a much better look than the Cochrane, because a lot of those were a little bit older studies, and all of the strategies that we used to care for the rest of the child had changed. But then looking at death, we're have a little bit of an increase in volume targeted ventilation, but we're kind of touching the line there where it's not really a big dramatic increase in the risk of death. Looking at length of ventilation, similar. It was an improvement with volume targeted ventilation. So overall, the majority of the studies aren't that overwhelming. And when you look at them individually, you see a big response in one, not a big response in the other. So when you're looking at the meta-analysis, it's kind of the best way to view them. But the big challenge in trying to do a meta-analysis, and with all of this, is we have multiple different types of modes, and it's still a big challenge. We're really looking at consistent ventilation strategies and comparisons, and a lot of the studies also varied their tidal volume target. A couple of the studies are starting to come out with, in your lower birth weight population, if you use too low of a tidal volume, that's really not using volume targeted ventilation that's the problem. It's your settings that were the problem. You really should be sticking right around your 5 milliliters per kilogram. And if you go less, if you go 3 per kilo or 4 per kilo, it was really the utilization of the mode that was the problem, not the mode itself, because too low of a tidal volume can also be harmful. And that's one of the big criticisms of several of the studies that are included in the meta-analysis and some of the newer ones that had come up. But it's really hard to take a look at any individual studies. We really need a large randomized controlled trial, comparing them with actual good protocols for ventilation for the pressure side as well as the volume side. And even if we have multiple ventilators, if they're at least using the same targets of 5 mLs per kilo, if you're using the modes in the same way, then that's a better comparison, and we didn't really have that in any of these. So we talked a lot over the past several days about what are the benefits, and there perceives to be a lot of benefits, but we still don't have any literature, unfortunately, to really tell us one way or the other, or the best strategy for use within each one of them. And then we still have a lot of challenges. Airway flow sensors are a benefit because you can get a really good measure right at the airway of your exhale tidal volumes, and that is what helps determine the pressures of your next breath. But the challenges with using those are astronomical. A lot of secretions, a lot of humidity, the extra dead space, the weight of some of them are really poor. If you're giving any sort of aerosolized medication while you're delivering volume targeted ventilation, the recommendation from the ventilator companies is to take the flow sensor out of line during that time frame. So you disconnect the ventilator, take the flow sensor out. You're not giving a very good overall ventilation during that time frame because you don't have your volume triggering, so you have to go to pressure mode, while you're giving the aerosolized medication that we don't really know that actually helps what we're doing, and then disconnect again to put the tidal volume or the flow sensor back in line to get your tidal volume. So oftentimes the other treatments that we do along with volume targeting ventilation really gives us a lot more of a challenge in what we're doing. And I find oftentimes, because we have respiratory therapists in the United States, our doctors get a little bit more disconnected about how certain things are done on the ventilators. So when they ask us to do things, and I give them a strange look, they're like, why? Why is that a problem? I'm like, do you know what I have to do that? So, and how many times I'm interrupting actual ventilation if you want me to give this medication that we're just throwing at the patient as a, well, let's see, it might work, let's give it a try. So those are a lot of the challenges with all the other adjuncts that we tend to use. Airway leaks are a huge challenge. It's really easy to stand here and say, if you get a leak that's greater than 30%, then you just upsize your tube. But there's a lot of risks with that intubation procedure on the infant, especially if you're giving additional medications, or if you're not giving additional medications. We've seen in some of the literature, some reviews that we've been looking at, all of our intubations, and infants whom are intubated without a paralytic tend to have worse side effects of intubation, more adverse events. So you're putting a lot of risk into that procedure, especially if you have someone doing the intubation that isn't highly trained. The infant is even at much greater risk to just upsize that tube. So we oftentimes just tolerate those leaks, and then your volume targeting ventilation isn't working very well because you're not really getting good measures. It's coming out the mouth. But I think our biggest challenge overall is really the knowledge base of, and willingness of the staff to use the machine. When I say the medical staff, I don't really mean just the physicians, but everyone, to really understand each individual, what that individual ventilator does and how it works, and what are the best ways to do it. We have the Draeger V500 ventilators, and we rarely do volume-targeted ventilation because there isn't really a great understanding, and we always have these huge airway leaks, so that we never really have this great opportunity to use it. And in our BPD population, which is the majority of what we have, it gets very challenging to do it on them anyways, and sometimes pressure is better. We put them in a lot of these different types of modes. We're on and off high frequency, so we don't have that great opportunity to really teach about it as well. So I think that as much as we've really over the last 2 days said volume targeting ventilation is the way to go and we really should do it, there's still a lot of challenges out there when we look at the literature, and we really have to look at the individual practice at each institution, and isn't going to work best on this individual patient, as there still isn't any really good clear guidelines for use. And if there's any discussion, I try not to go over everything we've already talked about. Yes?
Can you get back to the slide I understand that the aim of volume targeted is that it is a volume trauma.
Right.
And now the slide is saying that when you use a volume targeted, you will have a volume trauma because the pressure is much better. So this slide, although from screen, it looks amazing.
I know. It was one of the things that's very surprising about it. And even with our less than 1,000 kilo population, and I think honestly, a lot of this has to do with understanding of the use of the modes and how it was used in the comparison. So it's really hard to take a look without reading some of these studies. You can see the one study that was done in 1997 showed a great benefit, but that was in 1997. That was, so much has changed in the total care of the patient, of the premature patient since then. As Brian had mentioned with some of our surfactant studies, these all really need to be done again, and can we really take a look at them, take them to heart, and change our practice because of it? And that's part of the challenges.
This is what I want to say, is that simple is better. The things you know better will give you better. Sometimes you drive an automatic car and you don't know that you don't have to use your left leg, then you will do an accident. This is what we do and teach our young colleagues. If you don't know high frequency, don't go. If you don't know volume target, don't go. Don't make more than one, right? Pressure and volume, if you don't know the idea of the leak, and this is very important, otherwise you'll get bad results.
Yeah, chances are in these studies that show the clear benefit with pressure is they knew how to use pressure ventilation much better than they do volume. So it's a challenge to even do good studies.
So it was the wrong volume target.
Yeah, it could have been too high or too low, which is one of the big critics for some of these studies, and some of the negative outcomes are from Dr. Kessler, who is kind of the king of volume targeted ventilation. And when you drill down to some of these studies, it's very difficult because their volume targets are all over the place.
Is there a maximum of amount of leak to allow to continue volume ventilation?
There is really nothing in the literature. No one has really taken a look at that to say precisely it's this % leak or this much leak that you can have. That random number of 30% has been out there by some people because some of the ventilators companies have said that you're not going to get an accurate measurement beyond that leak. So the only studies that were done were by the ventilator companies for during their FDA approvals. And you don't always, they don't give you those so you can really take a look at to see how they've done the studies. And they always go on the conservative side because they want to make sure that their machine always functions appropriately. So if they say 30%, you might be able to go 35, 40, but we really don't know. And you have to really take a look at the infant to know if it's really how they're really functioning, because sometimes it depends on what side they're turned on. Now you have a 30% leak on your left side, you turn them to the right, now you have a 60% leak. So the variability of the leak sometimes is just as much as a problem because it doesn't really stay consistent.